afternoon. It is now 1 p.m. and the time that we would start our presentation today of the Kernel of Knowledge series. Thank you for joining. This is a web series that features an expert speaker, a topic that reflects upon the mission of the National Library of Medicine and the current initiatives of GMR. I'm Darlene Caskey, and I'm an outreach specialist for the National Network of Libraries of Medicine, Greater Midwest region, and your host for today. For my PowerPoint presentation I have here, and I will go over a few housekeeping items to start. Everyone's muted upon entry. That way we minimize extraneous noise. I really value your participation being with us, so at any point during the presentation you may ask a question or submit a comment using the chat box. Our webinar is being recorded and will be loaded to the NNLM YouTube channel with closed caption. Notification of when it is available will be shared via Friday GR Update listserv. If you're not on the listserv, contact me via email and we'll get you added. Finally, this webinar is available for 1 hour of MACE credit, that's the Medical Library Association. At the end of the presentation, I will provide a URL link box. A Greater Midwest region is to advance the progress of medicine and improve public health outreach through access to health information. Target population is our most medically underserved area. So for purpose, I created the Underserved Health Communities Map. We launched on May 1st. It's an assessment tool for GMR members which highlights the medically underserved areas in our particular 10-state region. On the site, you will find National Library of Medicine and NIH resources, health needs assessments, health ranking snapshots, and a variety of links to relevant community partners such as federally qualified clinics, public libraries, schools, and health agencies. Because we all know it takes a village to disseminate quality and accurate health information. So this map we created, just use this URL. And in our GMR, it's on our front page. You have all these tools in hand, such as our community assessment map. How do you begin your community outreach? Well, today we'll go into more detail about what it's meant by medically underserved areas or vulnerable populations. We'll explain what specific health and government payer and provider services are available to them, and share strategies for how we can engage and partner with these communities. Joining us today is Brad Wright. He's an professor in both Department of Health Management and Policy and the Public Policy Center at the University of Iowa. Holds a PhD in Health Policy and Management from the University of North Carolina at Chapel Hill, an MS in Health Policy from George Washington University, and a BS in Biology from the University of Georgia. He also has a postdoctoral fellowship in Health Services Research at Brown, and he teaches on the U.S. health system and health policy analysis. So in the video I'm going to show you, he will explain his research topics. And hopefully well, I won't. But we'll stop sharing my screen at this point, and actually with no further ado, going to hand it over to Professor Wright.
I'm really happy to be here and talk to you about strategies for how to engage underserved communities. And the picture that's on this title slide is an example of a free medical clinic that's put on called Remote Access Medical, if I remember the name correctly, and they travel around the country and place free clinics. So you may have them. It kind of underscores the need that exists in this country where we think of our healthcare as being so good, and it is in a sense if you have the right insurance, otherwise means to pay for it, and access to get the care that you need. We have some of the best healthcare, if not the best healthcare that can be anywhere in the world. But ultimately, there are a lot of gaps in our system, and that's kind of what I want to talk to you about today. So I'll start with characterizing really what we mean when we talk about underserved communities, give examples of types that we would consider underserved so that we're all on the same page about who these individuals are, and then about the programs that are actually in place to target the underserved, make sure we can get them care or try our best to do that. How the web resources that HRSA, the Health Resources Service Administration, has in underserved populations, and then just touch on a few strategies for how you might think about engaged underserved communities, recognizing that all communities are different. So it's difficult to speak to this topic, and it's really going to be highly applied. I'm going to more focus on higher level think about, on the ground wherever your community is. You'll have to tailor those strategies to your needs. So if we think about defining vulnerable populations, these are just any groups that are at greater risk of poor physical, psychological, or social well-being health. And different terms get thrown about that are really interchangeable. So you may hear vulnerable populations or underserved populations, the medically disadvantaged or medically frail, underserved. Some of what we consider vulnerable population groups, I've given you a sort of a list here, certainly not an exhaustive list. Going down the list, you might be surprised at some of the groups that are on there. So you might be so taken back to see the homeless listed, for example. But why are, when children, those are pretty large categories. Why would we think of them as vulnerable? I'll explain that as we go. Racial and ethnic minorities first. That's when people tend to think about that. We think a lot about disparities, and racial disparities tends to be the focus of race is a social construct. We know that through other research, that there's not a truly biological underpinning racial differences that we see. So it matters tremendously because there are these disparities. And let's think about things like structural racism. So are there institutions, be it getting a home loan or how someone's treated at a store, or differences in the care they receive in a healthcare setting, which brings up the notion of implicit bias. So without thinking about it, are providers sometimes treating their minority patients differently than they might whites? All things, it's a multifactorial problem. And the reason we care at the end of the day is that it leads to worse health outcomes in these minority patients. So, for example, life expectancy in blacks is about 6 years shorter than whites right now. That's an improvement from where it was if we go back to about 1970 when it was 7 to 8 years shorter, but there's any disparity at all. There's no reason for that. So just a purely biological clinical perspective. And there is this interesting paradox, this first generation paradox. You may have heard of the Latino paradox, or this exists with Asian immigrants, where the first generation immigrants are healthier than subsequent generations, their children and grandchildren. And the thinking behind that is that their sort of social determinants of health were like wherever they came from, those things change. And so you could think about the diet that a Japanese person might eat in Japan versus when they get to California and these less healthy options that are sort of there facing turn. And so you go from eating lots of raw fish and things to eating fast food and so on. And so that's what that means. Focus on children. Children are really important to think about from the standpoint of vulnerability because they're dependent on adults to get their health care. So the adult has to recognize that they have a need for health care, and it means things like they have to actually schedule the appointment with them, they have to transport them to get there, they have to be the one who interacts with the provider to understand what's going on, and they're the one who has to go pick up the medication, ensure that the child takes it. So there are these points where the children are completely dependent on adults to meet their health care needs. And really important because things that are not necessarily don't take such a big deal for kids, can have really profound impacts when they're played out over their life course. So children, lots of things are sort of growing and changing with them, and so small things can lead to big differences later on down the line. For women, even the modern workforce we have and so on, it's still the case that women are more likely to work part-time jobs, that they get paid less for the same work, that they have more interruptions in their work history because they might leave the workforce temporarily to have children. They have a greater risk of losing their insurance coverage because they're likely covered by a spouse's plan, so that leaves them subject to what happens if they get divorced, so without coverage, or if spouse loses a job, that kind of thing. They do than men generally, so that's a thing that's awarded. Life expectancy is longer for women than it is for men, but they're more disease, so the level of illness tends to be greater issues, even though they live longer. Women, this is rising, they tend to have issues around poor access to care. That's things like poverty in rural areas, issues around transportation or the time it takes to get to a healthcare provider, the topography. So I've shown a picture of the mountains. Then you're not very far as the crow flies to your provider, but if you've got to snake around a mountain to get there and say it's winter, that could pose a lot of challenges. So there's seasonality, seasonal aspects to this. It's the availability of healthcare in rural areas. So this is an ongoing debate around, do we have enough doctors or not? And people will say, yeah, we have enough doctors, but even the people that will admit they're not in the right places. They're not spread evenly. And so in a rural area, you may have to drive quite a ways to get to a doctor that you can see. The homelessness is a multifaceted problem. Have untreated medical problems, lots of untreated mental health and substance abuse issues. They're at increased risk for assault and victimization, and they're also exposed to the elements. So, especially in a place where you have really winters, that's can be deadly. So, lots of issues with the homeless. I'm showing this chart over on the right of this slide, the breadth of who the homeless are. So it's an estimate of about 3.5 million people in the country are homeless. You can imagine that coming up with those numbers is not the easiest thing to do. How do you count the homeless? It can be done, but it's probably not really accurate. You see that single men make up the bulk of the folks, but families are a really large chunk. So that's and then families would be at least one child. The children at 7%. Those are people 18 under who are on the street without their parents. Another group that's vulnerable. So a quarter of Americans are affected by some form of mental illness. Because of you knowing someone who has mental illness or having one yourself, even in a group of size, that's things mostly like depression or anxiety, more than it's some of the more severe mental illnesses, and are not as rare as we might think. The industry is plagued with disparities as well. And access, a lot of that depends on whether or not you have the ability to pay for it. Even up until very recently, insurance carved mental health benefits out and somehow thought that they were different than the rest of your needs, that somehow your brain is not a part of your body unless you're having a stroke. So it's interesting that has worked, but there have been a lot of pushes for they call mental health parity, so treat mental health and physical health equally. It's still a social stigma around it. People not very often to say, yes, I have a mental illness. It's something that they like to keep themselves. On here, Medicaid is the single largest payer for mental health. Imagine that kind of a circular lie of that, because a lot of people, if they're mentally ill, may have trouble holding a job, may have lower incomes as a result, and would be on Medicaid. This is a huge problem. Essentially, half of the American population has a chronic condition. 52% of that number have 2 or more chronic conditions. And you add that up, it's really expensive. So of all we spend on healthcare in the country, which at last count was about $3 trillion a year, 10% of that is for care for chronic conditions. It's definitely a focus for reform care system as well as represent a real as for things like coordination of care. It can be complicated for them to know how to manage all the different doctors they have to see, the medications they have to take, and so the disabled, by contrast, so sort of a different group, but they have intense care needs. So long care that's very expensive and lasts, as it says, for a long time. And for the kids, ironically, this is a group that's also dependent on others. So anytime you see dependency on others for your care, that puts you at risk. So what do we outline these different buckets of types that are at risk of being underserved or vulnerable? There's sort of 4 broad ways we can try to tackle this problem. One, insurance programs. Other is through public programs for specific populations. There are also public policies we can put in place to influence supply side issues, and then there's public support of direct service provision, and I'll talk about programs. These are like Medicaid and Medicare, with which I'm sure you're familiar. So Medicaid is our program for covering low-income individuals, which we expanded significantly under care. And Medicare is our program for the adults and disabled populations. And it is actually the group of dual eligibles that have Medicare and Medicaid. And so Medicaid will pay the long-term care of these individuals who need that, if they're disabled or older adults. Public regulations, example of that would be things like the VA, which doesn't really need an introduction as much as it's been in the news the last several years. Not for good things, although ironically just a few years prior to that, it was being lauded for having this great integrated electronic health record and being an example for what we need to do in the rest of the healthcare system. So it went quickly from being as an ideal system to one plagued by all kinds of problems and wait lists and unnecessary deaths. Make of that you will. There's the Indian Health Service. And that program that was started back in 1976 to provide care to Native Americans, reservations out in rural areas where access to care is limited. It's got its own healthcare providers. It's not a very popular program, and frankly, I don't know a lot about the IHS. I've not really studied it in depth, so I hesitate to say much about it other than I know it doesn't have the resources that it needs. I know also a lot of issues around between the community and the sort of outsider health provider community. So it doesn't seem particularly popular and kind of linked as a result, is my understanding. As far as public policies to influence supply issues, and by that I mean, are there providers in the place they need to be? They come up with some different designations. One is health professional shortage areas, or HPSAs, medically underserved areas and medically underserved populations. And so those are 2 different classifications, and it's possible that a place can be both a HPSA and an MUA. It's also possible that a place can be a HPSA and not be an MUA. So there's some overlap, but it's not complete. And programs use these 2 different classifications to determine ability for grant funds. For example, I'm going to talk about community health centers that should be located in a medically underserved area. You see the little box here for the National Health Service Corps logo go to health professional shortage areas. So you break down a little bit further. HPSAs consist of different types. So there are primary care HPSAs, dental HPSAs, there are, I think, mental health HPSAs, if I'm remembering correctly. They're broken out by whether they're in geographic areas, whether within a certain population group, or medical facility. And for medical facility, that usually means things like a prison, something where the population is confined and there are healthcare facilities there. And so they on these provider population to provider ratios. So, for example, in a geographic area, if there are more than 3,500 people per provider, then that would hit HPSA. You can last bullet point on the left that when the program was started, there were just under 2,000 HPSAs that were designated. Today, there are 5,900. So it has really grown over time. With the measured areas, the stuff on the right-hand side, that's based on an index of medical underservice, and that takes into account 4 factors. So it looks at the population that's below poverty, the population of adults, the mortality rate, and then the supply of primary care physicians. And it being too much into the weeds, uses all of that to create this end of medical underservice score. There's a line, there's a threshold put in place, and a score above the line. Then you're essentially, if you're below the line, you are. And what I want to talk about with this on this slide is National Health Service Corps. If you're familiar, that's a program that provides loan repayment for care providers to go out to underserved areas and deliver care. It's really effective as a recruitment tool. The problem with it, to the extent it would be one of retention. So how do you convince providers to stay in an underserved area after their med school loans or their nursing loans have been paid back? And the research on that is that you don't. It's really difficult. And draw of living in a more of an area, all the amenities that provides, and includes also professional advancement and the ability to network with other professionals, makes it really difficult to retain people in underserved areas. And so the research there is finding that the best way to go about doing that is actually to go to underserved communities to recruit students into medical school, into nursing school, because they'll have a tie to those communities and be likely to want to go back. In terms of service provision, what I mean there is this is grant-funded or charity-funded care opposed to a federally run program. Examples here are public hospitals, free clinics, health departments, rural health clinics, and federally qualified health centers. Familiar if you ever watched ER, that was based on Cook County Hospital in Chicago, so that's a public hospital. In Atlanta, people know Grady Health System. In Des Moines, we have Broadlawns Medical Center. All of these are public hospitals, typically financed by cities, and then is a charitable one. So they provide, as a result, a disproportionate share of uncompensated care. Very important institutions, and they do struggle, though, to continue operating because of that. So these are nonprofit organizations. They're volunteer staffed for the most part. That's an easy cost down, as you don't hire staff. They volunteer their time. Don't take any sort of third-party reimbursement. They view themselves as a place of last resort for care. This is my top slide showing the free clinic that travels the country and sets up these pop-up free clinics. Patients typically, or if they do, it will be on some sort of sliding scale based on their ability to pay. And they're depending very heavily on donations and sponsorship for their ongoing support. And also about them, this is a sort of tangent point, is that they can apply for liability coverage under the federal tort claim. And so with that legislation basically addresses this issue of why am I going to volunteer? If I'm a physician, if I go volunteer my time at this free clinic, they're stopping this person from suing me for malpractice. So a lot of providers were hesitant to volunteer time. And so what the FCA does is basically says you are in a federal government in this here. So if someone wants to sue you for malpractice, they're basically suing Uncle Sam. And it should come as a surprise that's a lot more difficult to do successfully. So this is really a piece of legislation designed to encourage more healthcare providers in these types of settings. Local health some people think of those as part of this healthcare safety net. They're really a reliable source of care. It really varies. So there are some health departments that provide lots of primary care services, but most don't. Yes, they'll do things like STD screenings or blood pressure checks. There are other safety net options available. They'll often point you to them. If there aren't, they may try to work out some ad hoc arrangements with local providers in town if you really have a pressing need, but even that's highly variable. Rural health came into existence in the late 1970s. The focus was really on a Medicare program. So Medicare started in 1965. Really, 6 was when people were in the program, and it suddenly became obvious that, wait, we had this insurance program, but folks that live out in the middle of nowhere don't have doctors, and so we need to give them points of access. And so that brought the rural health clinics into existence, give Medicare beneficiaries in rural areas access to care, and was to increase the use of nurse practitioners and physician assistants. So the law is that there must be at least one of those types of providers on site at least 50% or more of the time that the rural health clinic is open. And this works under a model where you can take one physician who might work in a rural area who can spend, say, 1 day or 2 days a week at a location and then spend some other days at another location or locations, kind of supervising these more mid-level practitioners. To extend the work of physicians. I hate to use the term physician extenders for nurse practitioners and PAs. They don't like that, and I agree with them, although it's hard to know what else to call it when you think about it. So the clinics are reimbursed on a cost basis, so that helps to offset the fact that they are in communities where they don't have as large of a volume of patients. And there are 100 of those in operation today, so not a small program by any stretch. Let me turn lastly, federally qualified health centers. So there were 5 different programs that started at different times, and they all got fitted under this umbrella of FQHCs in 1996. You can list it here. So community health centers, migrant health centers, healthcare for the homeless, which is really cool, as you might imagine, and then school-based health centers and public housing health centers. I'm going to spend my time focusing on a lot of my research is, and that's community health centers. So a program that you may never even heard of. It started in 1965 as part of the War on Poverty under Lyndon Johnson. Today there are 1,200 grantees, but it can operate more than one point of care, and so there are over 8,000 delivery sites. And so the program serves about 20 million people. I just actually was on a web this week. The number was closer to 25 million people. So it's about 1 in 15, or maybe a little better than that, Americans get their care from a health center, which is incredible. It's the largest network of primary care providers in the country, and plenty of people have never heard of them. They can be located in a medically underserved area or serve a medically underserved population. And one of the things they do that's neat, in addition to just providing primary care, is that they also provide enabling services. So those are things designed to increase the community's access to the health center, but they're not health care per se. So that might be something like transportation. So they may have a shuttle that they operate for people to access that way. They may have extended hours in the evenings for people who can't get off work. On-site child care, if you can't watch your kids. Outreach and enrollment for getting you signed up for Medicaid coverage, and on and on. There are a lot that I don't have time to talk about, but those are some examples of the kinds of things they do. The other side is that individuals who go to health centers often encounter difficulties access to specialists. So especially the uninsured, they can get to the health center because the health center has an open door policy with a sort of slight fee scale that they operate. Uninsured, and you can't pay anything, they're still required to see you by law, but they find a suspicious lump and think you need to go see an oncologist, or they hear a heart murmur and think you need to go to a cardiologist. If you're uninsured, that next level of care may be very difficult for you to obtain. So they do try to work out ad hoc arrangements in their community, but a lot of leadership points to that being a barrier for them. They're also unique in that they have patient majority governing boards. So 51% of their governing board has to be patient at the center. The idea being that that makes the center more responsive to the needs of the community. I've done some research in that space I don't have to talk about, but suffice it to say there's some interesting ways that they seem to get around some of that. Although they really do a great job of it, and it does seem to make a difference. So kind of a mixed bag. Why would a health center do all of these things? Bottom line is they get federal grant for doing it, which helps to offset the costs of the uncompensated care they provide. And they also get increased reimbursement from Medicaid and Medicare. So it's sort of similar to the cost-based reimbursement that rural health clinics get, although and they used to actually get cost-based reimbursement, but that has changed. But they still get paid better than a typical primary care provider. And again, you see this FTCA coverage, so the coverage for people that work in health centers. Okay. So now out to the web, and I don't have the stuff on here since I had to get onto a different computer. So bear with me one second. We'll see if I can work technology. All right.
Oh, you did it. Okay, great. No time for questions. Go on.
So I'm only going to show one thing in the interest of time, and that's the data warehouse. So this is just as main landing page for .gov. So navigate to the data warehouse. This is where all the stuff is anyway. And I'll just hover over these to show you how much stuff there is. Clearly can't cover all of this today. But if you go to topic areas, for example, you get health workforce. They have a lot of kind of web-based tools. So this means for health workforce activities, so I'll pick on Iowa. So we've got $15.7 million. And they click on Iowa, it'll actually show you where stuff is going. Johnson County, where I am right now, has a ton of that on. And you can't go past that level on this map, but I'll show you can get to some other stuff in just a second. So that was health workforce. Also interesting to look at, let's see, the National Health Service Corps, so the program I mentioned that sends to underserved areas. This will show you how many full-time equivalent health service corps there are in your area. So again, we have 82 of them. You can see where they're spread out. So there are a lot of places where we don't have any. And that doesn't mean that these places are not. It may be that they're so rural that they can support one. There may not be more for them to work. So in the case of Johnson County, though, I can promise you it's because we're not underserved. We have 2 hospitals just in Iowa City alone. So, but you go up to Lynn County, and apparently are, and I know that they have a health center in Lynn County and Cedar Rapids. So you get a sense of where these individuals that are getting these scholarships are based. Look at under primary the health center grantee profiles. This area. So again, I'm going to click on Iowa. It's just easier for me. Shows all of the. Oh, they always want you to take a survey. No thanks. All health centers in Iowa, and want data on them. So I mentioned into health center. So here it is. So it gives me their address. If I click on service area map, it actually pull that up. And now I'm level of detail. I can see where the patients come from based on zip. Cool. So that gives a sense of where they're coming from. I mean, so some of their patients are even going there from Iowa City, so from several counties, but the bulk is right around Cedar Rapids. And then they'll show you all kinds of data for several years, ACE, insurance status, etc. So something for you to play with and explore, to give you some of the resources in your area. If I go back, see if I can get away from this real quick to this tab. There we go. Back to, let's see. Oh, areas. This will actually show you the HIPSAs. Go to Iowa, so 318 different shortage areas in the state. They do 3 of them in Johnson County. Can't drill down past there. If you go to, there's a number of interesting things in here. I don't have a ton to do all this. I'll show you 2 things. One is this HRSA in your. So if you go here, this was everything that HRSA is doing where you are. You can select a region, you can select a state. So if I wanted to pick Iowa, it'll know by congressional district or by county. So everything that's happening in the Iowa District 2, like that. It shows and all that breaks down into different programs. So this is a really cool way to see everything across all of the different domains HRSA operates. And I touch really on a couple, and that's the sort of use of the HPSAs for the National Health Service Corps, which also relates to health workforce, and the Health Center program. But as you see down here, there's also a white program that gives money for HIV/AIDS, maternal health programs, and then does other things as well, like poison control centers and all kinds of stuff. So that, and then the other thing I was going to show you is find a grant, which might be useful. So kind of pick and choose. You have all these different programs, just at community health centers again, just fiscal year 2017. And it updates all these lists as you go through. So I'm picking the center program. I'm going to pick Iowa, and I'm going to all the counties in Iowa. So then I hit, and it'll give me all the health centers that we saw for Iowa before under a different list. They're all presented here. The cool thing about this actually is that it has the program director listed here with their phone number and email. So when we, as we've been transitioning and talking about how to engage these communities, here are addresses and contact information, as well as the amount of the grants that they got. So starting point for how to get in touch with these folks. So I'm going to get out of the website stuff and go back to my slides. Skip all that really quickly and try to do this in 5 minutes. I found for questions if people can. 2 different ways to think about goals with engagement. One is, are you trying to reach providers and in turn their patients, or are you trying more broadly to reach the community? Either of those groups, there are several things to try and appreciate. So one is, in underserved populations, there's a long history of discrimination, stigma. Oftentimes the views of these populations are marginalized, and frankly, they've been abused. So there's a lot of mistrust. So I say, think of the Tuskegee experiments, and I show a picture of that here. For those who aren't familiar, that was experiments done in Alabama on African-American men syphilis, and we had treatment for syphilis, but we withheld the treatment because we wanted to study the prevention of syphilis in these individuals. So it's all kinds of unethical. And I mean, this is actually something that when we train people about ethics, this is one of the prime examples. There's another one that they give of children that grew up in housing projects in Baltimore where it was known that there was lead paint. Kids were eating paint chips off the wall, and no one did anything about it because they wanted to study it. So because of those kinds of things having happened historically, individuals from these populations are very skeptical about outside and also don't want to participate in research as often as other groups. So that's something to keep in mind, and that relates to these sort of sociocultural barriers and power differentials as well. So that a picture of Sherpas, basically. Going to go climb Mount Everest, you need someone who knows how to get there, and so that's the idea here. The cultural brokers are people who have a knowledge of the community, its history, its needs. They know what programs are already in existence in the community. They know what resources exist, so that you don't go in and try to reinvent the wheel. They'll help you get a lay of the land, the existing relationships with people in the community, whether that's these existing programs and resources, or members of the community. And so that can help in establishing trust to make a way into a community where you might not initially be trusted otherwise. Sort of in a translational role, so some of the concepts that you might be wanting to talk about are sort of higher level, and people don't necessarily have the health literacy to understand them, and so they can help bridge the gap. And if you've heard of like community health workers, for example, that's one of the things that they really can do, is be someone that's closer to the community you're serving, and can help them understand what's important to keep their blood sugar under control, for example. If you're going to collaborate with these other groups and help make those connections, and they'll just tell you generally, that or that won't work here. So it's really important to find individuals as a first step. Examples of where to look for community partners. There's a whole bunch. This gets into, it will vary from community to community, but it may be a public housing authority, it may be a health department. Libraries themselves are a public resource. Barber shops are a big one. Especially in minority populations. The barbershop is more than just a place you go get a haircut. It's a cultural center. It's a place people will spend all day and hang out and have coffee and talk. So it's actually even been used to recruit research participants. Most communities, no matter how small, will have a place of worship, and they know the community pretty well. So and they're a trusted information. So that's a place to look. A lot of communities, even really small ones, have a post office. Once again, there's in every small town in America. So not necessarily the places that you would think of for making inroads with health information, but don't overlook them. More traditional sort of hospitals, support groups for things like AA or just that, community action agencies and centers, organizations that are like the Legion, the JCs, Kiwanis, and so on, service organizations with like food pantries, homeless shelters, and even first responder organizations. All of these are different doors to come on, basically. So that's all of my prepared remarks. I think I left us 5 minutes. Like I said, I could stay around longer. Questions. I don't have anything else to do until an hour now. Feel free to follow up with me on Twitter, too, if you want to follow me and send me messages there. I'm happy to respond, or me an email.
Thank you, Professor Wright. That was well worth the wait. Thanks for the technical difficulties, but that was well worth it. Questions? I still have everybody muted, but if you want to raise your hand, I can unmute you, or please put your question in the chat box. Again, if it's we are going to focus on these underserved health communities, and you did a very good job of explaining the different demographics, the stigmas, and some of the challenges, but gave us some good ideas of where we could start with projects. Anyone who is with us today, has anybody done any research projects with underserved communities before? This is giving some ideas of some work that you would like to do in the future. Any questions or any thoughts? Okay. Well, what I will do is I take the ball back from you, Brad.
Okay.
And there you are. I'll take the ball back. Now, screen sharing, and talk about the conclusion of this. We have, at the very beginning, you are eligible for MLA credit if you would like to receive that. Here it comes. And we take an evaluation survey to let us know how useful this program was for you. And here is the URL. You may jot that down. You'll take evaluation, and then you'll go on to receive your state credit. So any last comments, any questions, any concerns? I know that Brad had to speak very quickly, but you covered a great deal of information. I learned something definitely about finding the directors in those community health centers. I think that's a great start. Okay, from Caroline, can you talk about the role of social media, even technology issues in general? Here. You can start right yeah, thank you.
Okay. Yeah, so I think one of the things that's actually surprising, and it's funny because it becomes like the talk, political talk about like the Obama phone and stuff. But you'd be surprised, even low-income individuals have access to technology and are on social media. So that is kind of one area that I neglected to talk about. But I think it is an important one. Things are moving in that direction. So I think it would be incorrect to assume that these individuals don't have access to, say, phones, to internet access and all of that. They typically will. And so thanks for raising that. That's one of the things, as far as addressing workforce shortages, we're moving towards like things like telehealth, right? So we don't have to physically have a provider in the room with you. We can just have them on screen talking to you. They've even gone so far as having remote to medications, so that the medicines are in a locked drawer and you talk to the provider, and then once it's understood that this is the medication that you need, they can remotely unlock the cabinet and dispense the medicine. So certainly I think disseminating messages on Twitter, on Facebook or otherwise is a great idea.
I'll tell you about one recent project that the National Office funded. It was for a rehab center for homeless gentlemen, and after they'd had a surgery or procedure before they were sent away, needed additional time to recover, funded iPads for the healthcare workers who were meeting with them. They showed them their MedPlus resources and other resources on the iPad to answer their questions about how they could continue taking care of health conditions they had as they left the rehab facilities. We sponsored that report, and we're going to be, I'll be sharing the results of that project on the Underserved Community Health Map. And I want to be able to share more of these kind of stories in these areas and build a database, if you will, or a web page of all these kind of ideas of how we can engage with the communities and hopefully improve public health to good quality health information that we have from the Library of Medicine. Today's talk is it's great to understand the background and where we can find resources in these communities. With that, I think I will conclude the program because it is time. It's 2 o'clock. Thank you again. Appreciate everybody's patience, and I think everybody will think that was a well worth waiting talk. So again, and please take a survey, and thank you for doing it.